Welcome back. This is going to be part 2 of common paradental lesions. So the last video was radiolucent periapical lesions, just the most common things, and now the most common radiopaque and mixed ones, plus at the end we'll cover resorption. So just the most common things that you're going to see around the roots and the apices of teeth. So again, quick orientation on the chart. Previously, all we really focused on was the periapical inflammatory lesions, radicular cyst, and now we're going to slide down here to this well-defined radiopaque lesions, but things that are tooth associated at the periapices of teeth. And for that, we have this CHICO acronym to help us remember. And so think of 2 questions for sorting these different radiopacities out. First of all, is it attached to the root? See, these are the only 2 things, Cementoblastoma and Hypercementosis, that really appear attached like they come from the root of the tooth versus unattached. So all these things, you can think of ECO from the CHICO acronym, Idiopathic osteosclerosis, condensing osteitis, which we've already talked about, and Osseous Dysplasia. Those should not appear like they're co-joined with the tooth. And then the other big thing is there a radiolucent rim around it? Idiopathic osteosclerosis does not, nor does condensing osteitis, so although it does have a radiolucency of the apex. And osseous dysplasia, when it's mature, is when it starts to look opaque. That's why it's included here. And in most cases, it does have a radiolucent rim around it, sometimes varying in thickness, but then also surrounded by sclerotic bone. So let's get started here. First thing here is idiopathic osteosclerosis. It does have synonyms, and you need to know these because this is such a common thing. Anastosis and dense bone island sometimes refer to this, but the more technical term is idiopathic osteosclerosis. And this is just a localized growth of compact bone inside cancellous bone, so within the bone. It's well defined, a lot of times irregular in shape. It kind of fills in the marrow space, which is bordered by somewhat irregular trabeculation. Usually it's uniformly radiopaque, although that does vary. It looks like cortical bone, the same density as cortical bone, and may blend into the surrounding trabeculae. Rarely does it resorb a root. The key is what it doesn't do. There's no rim, there's no reaction, it just sits there. The periodontal ligament is perfectly intact around it. And so here's some examples for you. It does, for the most part, have sharp margins, really well defined, but it can be somewhat irregular as that trabeculation pattern around it is a little bit irregular. Here's one with root resorption. I said that's rare, but it can occur. Here's some CBCTs. This is an axial slice through the mandible, and you can see it kind of merges with the cortices here. This one tends to be a little bit less opaque, as does this one, but it has really well-defined borders. Anywhere you see it align the root of a tooth, specifically this one here really shows it. It just has a nice, well-defined, intact PDL space, so it's totally inert. No treatment is needed. All right, looking at this one, nice round lesion. What does it look like? Does it look like condensing osteitis? Remember that term. That implies a periapical lesion. I don't see any radiolucency of the apex. It's just an opacity with PDL space intact. Nothing going on with these teeth. And so the differential for this is basically the rest of the video, so treat this as a preview, but periapical osseous dysplasia, remember when you have the mature, most of the time it's going to have that radiolucent periphery. Dense bone island does not. Sclerosing osteitis, first of all, you're going to do the vitality test, and it should be on a non-vital tooth for sclerosing osteitis. That was our term for a radiopaque periapical inflammatory lesion. And sclerosing osteitis should also have a widened PDL space or some type of radiolucency at the apex that indicates that it's coming from the apex of that tooth. Hypercementosis has PDL space actually wrapping around the opacity, and that's one that's attached at the root of the tooth. Cementoblastoma, also attached to the tooth. Typically those tend to be really round with a soft tissue capsule or a somewhat thick radiolucent rim around it. And the difference there is that radiolucent rim on Cementoblastoma is thicker than PDL space that you see on hypercementosis. And so this is worth keeping in mind. Really important point for the rest of this course, for the rest of your career, because these things are so common. These different things, dense bone island, condensing osteitis, and mature osseous dysplasia, those 3 things occur frequently at the apices of the teeth, although idiopathic osteosclerosis not exclusively, and they can look very similar. Together those form an acronym which is part of our CHICO acronym from the differential diagnosis, just those last 3, or ECO. You'll see those come up over and over again. Those will belong on a similar differential, so keep ECO in mind. Idiopathic osteosclerosis, condensing osteitis, and osseous dysplasia. You separate them by context, rim, cause, vitality. I'm naming that now because you'll see it again and again. You'll see it again in the ill-defined radiopacity topic and the multifocal radiopacity topic. So learn it once here and remember it when it comes up again. I did mention that management for idiopathic osteosclerosis is really none. You just kind of monitor, make sure it's nothing else going on, right? You want to rule out that it's condensing osteitis, usually by a vitality test. But if they do have multiple DBIs, dense bone islands, That may be related to intestinal cancer. We'll talk about that when we get to our multifocal radiopacity lecture. But if there are more than 5 very distinct, somewhat large idiopathic osteosclerosis lesions, then you start thinking about this condition, which is Gardner syndrome, and we'll talk about more. And now on to Cemento-osseous dysplasia. These are just focal areas, always at the apices of teeth, where normal bone has been replaced by fibrous tissue and abnormal bone. And there's 3 different types of Cemento-osseous dysplasia. Periapical is the most common one, and that's when it's just isolated to the anterior mandible, so any of those 6 teeth. It can be multiple of those, and it'll still be called periapical Cemento-osseous dysplasia. Focal is for when it's a single site outside of the anterior mandible. Those tend to occur in the posterior mandible. And when it's more than 2 sites, so typically we talk about more than 2 sextants of the teeth, then we call it florid, and a lot of times that occurs all over the mouth. All right, so I said periapical is the most common one. It's in the anterior mandible. It tends to occur in middle age and more common in women, more common in black patients, Hispanics, Asians, more so than whites. And what do we say about vitality? You want to rule out that it's a periapical inflammatory lesion. That's why you do the vitality test. These will typically be vital, typically asymptomatic, and they typically don't require treatment. But the early lesions can really mimic a periapical inflammatory lesion, so be aware of these. That is the most common presentation. In fact, just looking at this, there's nothing going on with the teeth. I don't see caries. I don't see fracture. There's no reason to expect an inflammatory lesion, and this being the most common location for Cemento-osseous dysplasia, just based on these radiographs, that's what I would highly suspect over periapical inflammatory lesions, even if they look somewhat like inflammatory lesions. And so hopefully you know this by now. How can you clinically distinguish osseous dysplasia? Do the vitality test. For osseous dysplasia, you suspect that it's vital. Does that tell you necessarily it's an osseous dysplasia? No, it could be any of the other lesions we're going to talk about in this course. But it does rule out an inflammatory lesion. Now, these lesions, as they mature, they develop these dystrophic calcifications within the lesion. And so this is our mixed stage, where you have internal to the lesion, it looks radiopaque. Surrounding the lesion, it's radiolucent. And a thought question for you, how does it look different from a periapical inflammatory lesion? Because you can have condensing osteitis, where it forms opacity too. Is there any way to tell radiographically? Well, in any of those periapical inflammatory lesions, did you see radiolucency going around the outside of it? No, that doesn't tend to happen with a periapical inflammatory lesion when it's condensing osteitis. For those, you do expect to see the radiolucency around the apices, and then that's surrounded by a sclerotic region of bone, or radiopacity. What you don't expect to see is this continued radiolucency around it. Then another thing I might point out, when you see the opacity, the opaque portion of Cemento-osseous dysplasia adjacent to the root of a tooth, you have that nice, intact, uniform PDL space. And so this is just our typical periapical Cemento-osseous dysplasia, but now in kind of the mixed, more mature stage. And it is less common in the maxilla, but you will see that on occasion. This shows even more mature than that last slide, as now these radiolucent areas around the lesion is starting to shrink in size. But still, you can appreciate, hopefully, that there is a little bit of a radiolucency around it. And so keep that in mind. That's the thing that really distinguishes it. In this case, I would say it distinguishes it from anostosis, idiopathic osteosclerosis, because of the apices of the teeth. I don't see anything really that looks like a periapical inflammatory lesion. So keep that in mind. But yeah, so Cemento-osseous dysplasia, not idiopathic osteosclerosis, mainly because of the surrounding radiolucency around the outside of it. And eventually they can grow completely radiopaque, a very mature lesion. That's pretty rare for them to lose all sign of that radiolucency around it. In fact, this is one of the more opaque mature lesions that I've seen, and you still see that hint telling you what it is. All right, and these are just other variations of it, maybe a wider radiolucent component. Sometimes these are associated with simple bone cysts, which we'll cover later, especially the Florid type. But sometimes that cystic component of it can be larger than others. It's still just periapical Cemento-osseous dysplasia. You can just see the variation here. All right, now let's talk about Florid, widespread form, when it's extensive throughout one jaw or 3 or more quadrants. I believe the pathology book talks about it being more than 1 sextant. So if it was isolated to the anterior mandible, that's just your periapical. But once it extends into the posterior and it's multiple sites, then you're going to start thinking Florid Cemento-osseous dysplasia. And these tend to be even more expansile in some cases, not always, but they can be more expansile than your periapical. More common in the mandible, but frequently extends all throughout the jaws. If you looked at this based on those previous images, would you guess it's Cemento-osseous dysplasia? They look quite larger, right? But they have well-defined borders. There's this internal radiopacity. All these various teeth, it doesn't look like they have multiple periapical lesions because there's something opaque going on. Show you some more examples. This one's a little bit more cystic. If they biopsied this would probably end up being a simple bone cyst, or that's what the histology might come back as. But you want to try to avoid biopsying these because there's less vascularization, they're more prone to infection. So these are a really important one to be able to recognize radiographically and say, hey, this is a no-touch lesion, meaning we don't want to operate unless absolutely necessary. And these can hide periapical inflammatory lesions, so a lot is going to rely on your vitality testing of the teeth. And if the tooth is non-vital, especially if they have a large caries or restoration like this encroaching the pulp, then you've really got to rely on your vitality test. This one, if we didn't just cover Cemento-osseous dysplasia, can be confusing for a lot of people because it looks mostly radiopaque with some mixture in here, but this is just a very mature, you can see it's an older patient, a mature Cemento-osseous dysplasia, and it's the Florid type, right? And there's one other type I didn't quite mention in this presentation, but when it's in a single region outside of the anterior mandible, typically that occurs in the posterior mandible, then we call it focal Cemento-osseous dysplasia. So periapical, the most common, the anterior mandible. Focal for when it's one area outside of the anterior mandible, and then florid when it's multiple areas and can be widespread. So remember, this is key to management. You need to be able to provide a proper radiographic description and differential diagnosis. It's not going to be considered the final diagnosis, but as I said, these are susceptible to infection, so you want to avoid biopsy unless absolutely necessary. And treatment's not advised unless there are other complications. Some of these florid ones that can go really large and expansile, and treatment may be inevitable in those cases, and so that should be handled surgically. All right, let's move on to hypercementosis, which is just excess cementum on the root of a tooth. Usually the cause is unknown, but sometimes it's been associated with inflammation, hyperocclusion, Paget's disease. Those patients tend to have more hypercementosis, but the appearance of this is a giveaway. The PDL space wraps around in a large part of the root, looks pretty bulbous, usually the apical portion of the root. The root looks fat, but it's still wrapped in the normal PDL. And so again, you probably want to vitality test these teeth and rule out an inflammatory lesion. There's no treatment for these, but if you do need to extract one of these teeth, keep in mind now you're kind of extracting a tooth with a root that's like a ball in a socket. And so that's going to be a lot harder and more likely to risk needing a surgical extraction. All right, some examples. This looks like a large bulbous root. This is one of the largest examples of hypercementosis I've seen, but look at the PDL space. It's nice and intact and uniform. Doesn't look enlarged anywhere. And this is the more typical appearance, just kind of widened, enlarged apical portion of the roots with an intact normal PDL space all the way around these. So keep that appearance in mind. You'll see hypercementosis all the time. Here's one more example. Imagine this root kind of looking like a fishtail, but it's that PDL space that gives it away. All right, how are you going to differentiate hypercementosis from lesions that originate outside of the root, like idiopathic osteosclerosis or inflammatory lesion? Follow the PDL space, right? The PDL space is intact, it's around it. The radiopaque portion itself looks like it's attached to the root. And then here's another one where the radiopaque portion looks like it's attached to the root. This isn't actually that common, but I wanted to include it in this lecture because it is important to include this on the differential and differentiate this when you see something that looks like hypercementosis. But what's the big difference here? This looks really round and bulbous. Most examples of cementoblastoma I've seen have a very round, like ball-like appearance. And instead of a normal PDL space, hopefully you can appreciate the difference, this is a little bit wider radiolucency around the lesion itself. And so that's the big thing that separates this from hypercementosis. Another thing that might distinguish this is your clinical signs. Notice that cementoblastoma is typically painful, but it responds really well to anti-inflammatory drugs. So if someone has pain, ibuprofen or aspirin, Tylenol, take it away really effectively, that's a good indication that it might be a cementoblastoma. So if you vitality test a tooth like this because they have pain, but the tooth tests vital and you don't suspect an endodontic lesion, it looks like it's attached to the root, a little bit wider than PDL space rim around it. Those are all indications of cementoblastoma. All right, cementoblastoma does have a somewhat specific area where they tend to occur, usually in the mandible on the first molar or premolar. Typically very well defined with that radiolucent band that I've already described. And then they're almost always perfectly round. Internally, they're mostly radiopaque. Sometimes they do have a little bit of a pattern to them, and in fact, they can have a spoke wheel type pattern. So this is one of the spoke wheel lesions. It can obscure the root outline because it's fused to it. Sometimes it looks like the root is resorbed where it's attached to it. And these can get expansile. They can perforate the cortex. So let's look at some examples here. Here's a nice periapical radiograph. This one doesn't look quite as dense. Maybe it has a little bit of that radiating pattern. It does look almost like the root is resorbed here, but it's attached to it. And then look at the radiolucency around it. Notice again how it's nice and round. All of these lesions are very round and ball-like. This has more of kind of a granular ground glass internal appearance, but look at the thickness of the radiolucent band around it. This is from a sagittal slice in a CBCT, just of note. And then these are from the coronal slice or the cross-sectional slice. But now we can see the cross-section of that bone and see that it's kind of resorbed through the buccal and the lingual cortices of this bone, and that nice round appearance. What I like about CBCT and 2D imaging is they look similar in both, right? That nice round appearance. In this case, we'll talk about the radiolucency as the hypodensity around it. And then this one, I think, really shows best that spoke wheel appearance. So that's nice. Sometimes you can see that, the appearance of the resorbed root, but it's attached there. There's no PDL space. And there's no PDL space around this. There is a radiolucent rim that kind of varies. And so let's contrast that to some of these things we've talked about. For periapical cemento-osseous dysplasia compared to cementoblastoma, osseous dysplasia has no symptoms. Not quite as uniform in appearance for osseous dysplasia. Remember, that kind of varies in the amount of calcification internally, where cementoblastoma tends to be more radiopaque. That radiolucent band around the cementoblastoma. And then osseous dysplasia doesn't tend to be quite as round. In fact, all of these don't tend to be quite as nice ball-shaped round like cementoblastoma. Sclerosing osteitis, does that have that radiolucent rim around it? No. Dense bone island doesn't have any radiolucency to it. Hypercementosis, we've talked about. The big thing there is it's a PDL space surrounding hypercementosis, so it's nice and thin and uniform. A little bit thicker radiolucency on cementoblastoma. And these don't expand like a cementoblastoma will. No pain with hypercementosis in most cases. All right, management for these. Self-limiting, meaning they do have a limit to their growth potential. These are typically a simple excision, so they will require surgical excision. In most cases, extraction of the tooth, but in some cases you may amputate it from the tooth and then treat that tooth endodontically if you want to save that tooth. Kind of depends on the size of it, how much of the root has been lost, right? A lot of considerations with the treatment of this, but it's a very benign lesion. And last topic here, let's get on to root resorption. Really, I just want you to recognize these once you've seen several examples. I think it'll be pretty straightforward. And just differentiate when it's external resorption, the outer root surface, versus internal resorption, which resorbs from inside the root itself, the pulp chamber, and outward. And then this may occur spontaneously, external resorption, but sometimes it's response to other cysts and tumors, inflammation, excessive force on the teeth. We'll see this happen in orthodontics a lot. When there's excessive force on the roots, they can tend to resorb. Most common place is going to be the apex, and then the next most common, sometimes we see it at the cervical region of teeth. And the bone and the PDL space kind of grow in. So the bone grows in and that PDL space stays intact and normal, so it follows the resorbing root. So examples here, just our typical apical resorption. Usually the roots don't quite blunt as they do here. The root is usually going to become more conical at the apex rather than flat and blunted. But do you see any indication of periapical radiolucency? No, the PDL spaces are completely intact. Some other examples here, just very short-rooted. It just looks like short-rooted teeth, basically, when it's external apical resorption. All right, then what about here? This one's pretty easy to notice because it's on the distal surface of that tooth, and then you see the bone kind of growing in here, and you have intact normal PDL space. In these cases, how can I tell this is coming from external and it's not internal resorption? Well, internal resorption is going to occur from the pulp space or the canal space, and that canal is intact and normal. So these are occurring either from the buccal or lingual, and always good when you can have a 3D view. Now we have a cross-sectional view of, this looks like a central incisor, and the bone looks pretty normal. It's just kind of growing in. Sometimes we call that replacement resorption. Normal intact PDL space. And so this is external resorption on the lingual surface of the root of that tooth. All right, internal resorption, usually unknown cause, just like with external, but it can be associated with tooth trauma, pulp capping, or enamel invagination. And all it looks like really is enlargement of that pulp or canal space. And here are some examples. How is this one different than those other ones where I showed and I said it's probably on the buccal or lingual? Well, in this case, the canal itself widens around it. And so it looks like a snake that ate a rat, right? This is the same thing, but it's very wide. This is getting wide enough it probably compromises the tooth structure. What about this one right here? Well, that pulp chamber, the root canal space is intact, and so this is external. What it really looks like is a radiolucent composite, and you guys should be familiar with that at this point. Here's another example. Here it looks like the root canals just kind of end, but then they widen, around this well-defined resorbed portion of the dentin. All right, so that's the radiopaque, periapical region and resorption. Again, from our differential diagnosis chart, that was Chico, and maybe we went into CO5 a little bit. Also, your dense trio, the eco lesions, ICO, remember those ones? Hypercementosis, Cementoblastoma, all sorted by attachment and the radiolucent rim around it. Across both videos, 2 questions did the heavy lifting. That was tooth vitality, and for the opacities, is it attached and does it have a radiolucent rim around it? For the next topic, we're going to go into the well-defined unilocular radiolucencies and meet the master differential for those, the DOA orcas. So see you on the next one. Thanks.